Coming up in this episode. Now, if the patient, in addition to their orthostatic hypotension, if they have intercurrent hypertension at other times, especially if it's supine nocturnal hypertension, then the management really can be very challenging. And it's another example of a tricky situation where you occasionally do need to give a combination of fludrocortisone and or midodrine and also give an antihypertensive at the same time. But again, this is another classic example of having the tap turned on and having the sink unplugged at the same time. So you want to avoid that if you can, but unfortunately, in tricky cases, you can't always avoid it, and sometimes you do need to do that. Hello, and welcome to the next installment of Risfeld Neurology Education, a not for profit, free open access project with a philosophical touch, exploring all areas of clinical neurology, meant for medical students through to neurologists and all health professionals caring for patients with neurological conditions. This is another episode in the Movement Disorders and Parkinson's Disease series, and it's titled Parkinson's Disease Common Ward Management Dilemmas. I'm your host, Tom Risfeld, a neurologist, epileptologist, a neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Before we begin, a legal disclaimer. The content of this episode is for educational purposes only. So let's dive into it. What I'd like to achieve in this episode is to assist mainly junior doctors, not just junior doctors, but largely junior doctors who are involved in the care of patients with Parkinson's disease on the wards at a day-to-day level. And there's a few different common or important scenarios that come up frequently that you need to know how to manage. And there's 5 in particular, and I'd like to talk about them today. But before we do so, it is important that you have a level of familiarity with the medications that we use to treat Parkinson's disease and their mechanisms of action. So this isn't going to be a pharmacology lecture, but I do just want to briefly go over the fundamental aspects of the mechanisms of actions and the drugs that we use. So just give me 2 or 3 minutes to do so. So firstly, regarding the pathway of levodopa metabolism, you give someone levodopa peripherally, and then it is broken down before it even crosses the blood-brain barrier, if it's not given with something to prevent this, by an enzyme called DDC, which is dopa decarboxylase, into dopamine. And that's a problem because it's broken down into dopamine before it's even crossed the blood-brain barrier and entered the central nervous system. And dopamine on its own can't easily cross the blood-brain barrier or get to the central nervous system. So that's a problem. Levodopa can also be broken down peripherally by another enzyme called COMT, C-O-M-T. Then, if the levodopa isn't broken down and it manages to cross the blood-brain barrier, it then becomes central. So it's in the central compartment, and it enters the neuron, and it enters the presynaptic neuron in particular, and it's converted into dopamine. It is then broken down by 2 other enzymes, MAOB, so monoamine oxidase B, or again, it can be broken down by COMT, C-O-M-T, but the central version of COMT. If it's not broken down, then it exits the presynaptic neuron and it enters the synapse and sits in the synaptic cleft and then acts on the postsynaptic neuron dopamine receptors, and it does its job. So what we're doing when we're giving dopamine or a dopaminergic drug is we're trying to affect this pathway. So what drugs act on the pathway? Well, there's levodopa, of course. Then we've got to find a way to block the dopa decarboxylase, the DDC, in the peripheral aspect of the pathway. And there's 2 drugs that can be used to do that, essentially. There's carbidopa or benserazide. And you can't really get oral levodopa on its own. It's always in combination with either carbidopa or benserazide. So there's different proprietary brands, which are a combination of either levodopa carbidopa or cocarbidopa, cocaraldopa, or a combination of levodopa and benserazide. Now, there are also peripheral COMT inhibitors, which we sometimes use. So the main one I would say is entacapone, And that can also be given in combination with levodopa and one of the DDC inhibitors in a brand called Stalevo. That's one of the brand names for that. Or you can give a different peripheral COMT inhibitor sometimes called opicapone. There is another one called tolcapone as well, but I don't see that used very often in Australia. Then there are also central COMT inhibitors, and the main one of that is tolcapone, so that does both peripheral and central COMT inhibition, whereas the entacapone and the opicapone are only peripheral COMT inhibition. Then you have your MAOB, your monoamine oxidase inhibitor B type inhibitors. So there's 3 of those, and all 3 are used. So selegiline, razagiline, and safinamide are the ones to know there. So I'll say them again: selegiline, razagiline, and safinamide. Then there are some other drugs acting on the pathway as well. There's a drug which predominantly increases the synaptic dopamine availability, and that's called amantadine. Although amantadine is a complex drug because it has multiple other mechanisms of action as well. So it has NMDA antagonism, it increases dopamine release, which is one of the main ways in which it increases the dopamine availability in the synapse. It can also block dopamine reuptake as another way of increasing the synaptic dopamine availability. And it also has some effects as a negative nicotinic acetylcholine modulator. Then you've got your dopamine agonists. So they're chemicals, drugs, which are acting to activate the dopamine receptors on the postsynaptic neuron, even though they're not actually dopamine or levodopa being broken down into dopamine. They're drugs with different chemical compositions, but they still act as agonists at the postsynaptic dopamine receptor. So the 2 main ones that you're likely to see used, or at least that I see used, are pramipexole and also retigitine. And retigitine is an important one to know because it comes in a patch form. There's also bromocriptine and ropinirole, although I don't see them used often in Australia. And then lastly, you've got your advanced Parkinsonian therapies, and we'll discuss these in a different episode. That's not for today's episode, but just so that you know what they are, you've got your intestinal levodopa preparations. So they're given by a PEG-J tube usually. There's also a new and upcoming drug, which is foslevodopa, which is a subcutaneous infusion of a form of levodopa. Then you've also got subcutaneous apomorphine. And then you've also got neuroprocedural, I should say, interventions, which consist of deep brain stimulation, DBS, to one of 2 targets, either the subthalamic nucleus, the STN, or to the globus pallidus interna, the GPI. So we all know now about the basics of the drugs that are used to treat Parkinson's disease. So what are these 5 dilemmas that I mentioned earlier? Dilemma number 1, the patient cannot tolerate their oral medications. So for whatever reason, the patient isn't swallowing their tablets. Maybe they're delirious, maybe they're obtunded, maybe they're fighting you, maybe they've got a bowel obstruction. For whatever reason, the patient cannot tolerate their oral medications. So there's 2 options here. The first option, which is the preferred option, is to insert a nasogastric tube to facilitate the enteral medications, and this is always preferable. If you have a non-crushable or a modified release formulation of levodopa, then that can be converted to smaller or more frequent equivalent doses of immediate release formulations so that they can be administered through a nasogastric tube. This is preferable to the second option that I'm about to tell you about because conversions to other agents are less ideal, because by converting the levodopa to some other agent, you're changing the patient's Parkinsonian regimen. It's likely that they're going to be less effective, and it's likely that they're going to have more side effects, including delirium. So if you can just do a nasogastric tube, go for it. Do that option. If a nasogastric tube just is not possible, or if there's a clear contraindication to a nasogastric tube for enteral medications, such as the patient has some surgical comorbidity, maybe they have a bowel obstruction and they're on bowel rest, and you can't give enteral drugs, they're not going to be absorbed, or something along these lines, then the second option is to convert the oral medications to a different route. And usually that means a transdermal route. with a retigitine patch. But it's important that this is done temporarily for the shortest duration possible. Now, one phone call I get all the time is, how do I dose the retigitine? Well, thankfully, there's a calculator that you can use to do the maths for you, and it's called the optimal calculator, and it's been developed by the NHS in the UK, despite the dodgy looking URL. So the URL is www.parkinsonscalculator.com. Thought they could have had NHS or UK or a .org or something that looked vaguely official, but they chose to go with an unofficial looking URL, but it is actually the proper calculator, which is vetted by the NHS. And if you're watching the episode on video right now, I've just included a screenshot of an example of how it works, but I'll describe it for those who are listening on audio as well. So you just put in the patient's normal drugs. So I've made up an imaginary patient here, and I've said that they're on levodopa-carbidopa, so that's co-carbidopa or co-caroldopa, and the brand that I chose here was Cinemet for this fictional patient, and they're on 100/25 milligrams per dose, or that can be also stated as 125 milligrams per dose, and they're on that 4 times a day. And this patient is also on pramipexole, and they're on a 0.5 milligram salt, which is 0.35 milligrams of base pramipexole, and they're on that 3 times a day. So I've put that in the calculator and then clicked calculate, and it says that this converts to the equivalent of a retigitine patch 16 milligrams per 24 hours. But if the patient has dementia or delirium, then we advise retigitine 12 milligrams per 24 hours. And then it says, please note the maximum dose of retigitine is 16 milligrams in 24 hours. Don't cut patches to achieve the required dose. So that's the way that I use the calculator to convert oral Parkinsonian medication regimens into retigitine patches if a nasogastric tube is not an option. And that's, in my experience, what most people in Australia do. And I presume people in the UK and elsewhere use this method or similar methods. Dilemma number 2. The patient is delirious or psychotic owing to their anti-Parkinson medications. What do I do? So there's a few ways to approach this. Firstly, it's likely that you're going to have to do a gradual step down in the patient's anti-Parkinsonian medications. But then that begs the question, how do you do that? What order do you approach the step down in? Well, there's a general principle here. You want to wean and or stop any anticholinergics if present first. Then you want to wean or stop any dopamine agonists or opicapone or amantadine, because they are the usual suspects. They are classic offenders in terms of causing delirium or psychotic features. Then the third line of drugs that you want to wean or stop are MAO inhibitors or other agents. And then the fourth line, the last line of drugs that you want to wean or stop, is the levodopa itself. So I'll say that again just briefly, just to reiterate to aid memorization. The first line that you stop are the anticholinergics. The second line are the dopamine agonists or opicapone or amantadine. The third line are MAO inhibitors or any other agents. And the last line, the fourth line, is the levodopa itself. The other things that you need to do is you need to evaluate for any other contributing factors that may be present. Why has this patient suddenly become delirious and psychotic? Is it all just the medications, or is there something else at play, and can that be addressed? And in particular, you've got to look for occult infections. Does this patient have a delirium because they've got a UTI? Maybe it's not the medications that are at fault. Maybe you just need to diagnose and treat the UTI, and that'll fix the problem. So don't forget to do that as well. And thirdly, if you're not winning with the 2 methods I've just described, occasionally there may be an indication for giving an antipsychotic in addition to their Parkinsonian treatment. But this is a classic example of something that I mentioned in the introduction episode to the entire Rispeld Neurology Education project, which is the analogy I like to use here is it's like having the tap turned on and having the sink unplugged at the same time, because the patient is on their Parkinsonian drugs, which are dopamine therapies, pro-dopaminergic therapies, and then you're putting them on an antipsychotic at the same time, which is a dopamine antagonist. So you're doing these two directly contradictory treatments at the same time. Sometimes you've got to do it though. It sounds counterintuitive, but sometimes you do just have to do that, but you try and do everything else first. If you do have to do that, then you want to use the lowest doses of an atypical antipsychotic with the lowest extrapyramidal side effect risk profile. So what does that mean? It means using quetiapine or pimavanserin or clozapine if really necessary. So obviously clozapine is more potent and there's lots of significant side effects that you need to look out for, such as myelosuppression. So you need to do careful full blood count monitoring and myocarditis. So you need to do careful ECG and other forms of cardiac monitoring. But if you really need it, then maybe the patient just needs clozapine. So that's always something to bear in mind. Antipsychotics that can be used, but you need to be more careful with, are risperidone and olanzapine. So they're kind of on the next tier. So the first tier, to say it again, is quetiapine, pimavanserin, and clozapine. And then the next tier is risperidone and olanzapine. And then the ones that you should really avoid are haloperidol and other typical or first generation antipsychotic agents. Now let's go on to the third dilemma. My patient has labile blood pressure or autonomic dysregulation, especially orthostatic hypotension, maybe with supine hypertension. What am I going to do? So this is also a good example of a tricky case. So the labile blood pressure is going to be a combination of the Parkinson's disease itself and also the treatment of the Parkinson's disease with the levodopa. So both the underlying disease and the treatment of the disease can cause orthostatic hypotension, autonomic dysregulation. So the first line treatment, which everyone forgets about somewhat frustratingly, is the non-pharmacological treatment. So what does that mean? There's 4 or 5 things here. The first thing is maintain euvolemia. So make sure the patient's nice and hydrated. Secondly, provided there's no contraindication from a cardiac or renal or hepatic perspective, have some liberal salt in your diet. This is not the time to do a salt-restricted diet. If anything, add a bit of extra salt to your food. Thirdly, compression stockings, assuming that there's no moderate to high grade peripheral arterial disease, which is a contraindication to having some compression stockings. That's very important. Fourthly, a basic one, but do some calf exercise before you stand up. So get that vascular pump working before you stand up and then stand up slowly. So basic behavioral modifications. And then the fifth one, which is why I said 4 or 5, is occasionally we might also recommend abdominal binders. So that's kind of taking compression stockings in the legs to the extreme and applying a compression to the abdomen as well to really try and push that blood up from the lower half of the body up towards the heart and the head where it's needed. But that's a pretty inconvenient thing to be wearing an abdominal binder all the time, and patients don't really like them. So a lot of the time we don't use them, but it is an option on the list and sometimes they can be helpful. What's the next thing you do? Look at what antihypertensives the patient's on. So if the patient's on antihypertensives, then get rid of them if you can, or try and at least rationalize them, optimize the doses and the dosing times to try and get the balance right. And similarly, where possible, you should optimize their Parkinson's treatment. So don't be over-treating the patient. If the levodopa is contributing to the problem and they're on too much levodopa from a motor perspective, wean back on the levodopa if you need to. Or if they're not being put on too much levodopa, but there seems to be a peak dose effect, then you could try smaller but more frequent doses of the levodopa rather than having bigger, less frequent doses of the levodopa. Then if that's still not working, if you're not winning with that, then you move on to your pharmacological options for treating the orthostatic hypertension directly. And you've basically got 3 options. Your first option is fludrocortisone, which of course is a mineralocorticoid, and so that's activating the renin-angiotensin-aldosterone system, as opposed to, say, spironolactone, which is a mineralocorticoid antagonist, which is doing the exact opposite of that, or drugs like ACE inhibitors and angiotensin receptor blocking agents, which are also drugs that act against the renin-angiotensin-aldosterone system. But by giving fludrocortisone, you're activating that system, so you're promoting salt and water retention to boost up the blood pressure. But you can run into troubles there if the patient has cardiac or renal or hepatic contraindications or comorbidities, and you can cause excessive fluid accumulation, so you need to be careful there. The second option, which can be used instead of or in addition to fludrocortisone, is midodrine, and that's an alpha-1 agonist. So that's essentially causes peripheral vasoconstriction. It's a vasopressor in a sense, and it's oral, which is good. But what do you need to be careful of? You need to be careful of any coronary contraindications in particular. So if the patient has nasty, brittle ischemic heart disease, coronary artery disease, if they have LAD stenoses that haven't been dealt with, if they are a vascular path, then you may not be able to safely use midodrine. So that's the main contraindications there. The third option is droxidopa, which is a prodrug for noradrenaline. And so that clearly is also a vasopressor. But droxidopa is not easily available in Australia. I'm not sure about in other parts of the world, but it's really not easy to get droxidopa here. So that's not a medication that I often use. Now, if the patient, in addition to their orthostatic hypotension, if they have intercurrent hypertension at other times, especially if it's supine nocturnal hypertension, then the management really can be very challenging. And it's another example of a tricky situation where you occasionally do need to give a combination of the above agents and an antihypertensive. So you might need to give fludrocortisone and or midodrine and also give an antihypertensive at the same time. But again, this is another classic example of having the tap turned on and having the sink unplugged at the same time. So you want to avoid that if you can, but unfortunately, in tricky cases, you can't always avoid it. And sometimes you do need to do that. And you have to think carefully about the doses and the dosing times that you're using. So if it's supine hypertension, which is nocturnal, maybe you want to use a relatively short-acting but potent antihypertensive, which is administered at nighttime, for example. And it can be quite helpful to get a renal physician or a cardiologist perhaps involved in the care of the patient at this point as well for expert advice on difficult blood pressure management if you're not winning. Dilemma number 4. My patient is frozen. They're in an off crisis. What are you going to do? Well, obviously, if the treatment has been omitted or delayed, you're going to reinstitute their antiparkinsonian therapies ASAP. And we know that antiparkinsonian treatments are time critical. And if you've done that and it still hasn't done the trick, or if the patient is frozen and off and they haven't missed any medications, then you're going to need to escalate their treatment because their treatment is insufficient. If you're the neurologist, then you do that yourself. If you're not the neurologist, then you discuss it with the neurology team and they'll be able to advise you on the best way to escalate their treatment. It's important to recognize that if the patient has progressive Parkinson's disease, so they're in the later stages of their Parkinson's disease and it's becoming drug refractory, so they're getting excessive motor fluctuations, which are becoming increasingly difficult to adequately manage pharmacologically. So they're getting excessive ONS or dyskinesias after the dose of levodopa or whatever other agents you're dosing them with. And then they're getting excessive wearing off periods prior to the next dose. And this is happening despite escalating both the dose of each dose and escalating the dosing frequency. And maybe the patient's having 6 times a day, 7 times a day dosing, and they're still getting these massive excessive motor fluctuations. Then it's probably time. In fact, it was probably already time a while ago, but it really does sound that at this point it's time to consider an advanced Parkinsonian therapy for your patient if the patient is a candidate for an advanced therapy. So, as I mentioned earlier, subcutaneous apomorphine or subcutaneous phospholevodopa infusions, intestinal levodopa gel infusions, or a surgical solution with deep brain stimulation to the subthalamic nucleus or the globus pallidus interna. But again, discussion on those advanced therapies will be the subject of a different episode. Now, the fifth and final dilemma that I'd like to discuss in this episode is a Parkinson Parkinson-hyperpyrexia syndrome. Now, this is not a common dilemma, but it's an important dilemma, and that's why I've included it here. So thankfully, it's not common, but it's important because it's really nasty. So you don't want to misdiagnose this, and you need to get onto the treatment ASAP if the patient does have Parkinson-hyperpyrexia syndrome. So what is it? It's essentially an abrupt dopamine deficiency state, usually in the context of missed or withdrawn doses or regimen changes. And the way to think about it is that it's basically akin to neuroleptic malignant syndrome, which is also an acute state of an effective dopamine deficiency. But in the case of a neuroleptic malignant syndrome, that's precipitated by giving dopamine antagonists. So maybe the patient got some haloperidol or some other antipsychotic agent, and that has antagonized dopamine and it's caused a neuroleptic malignant syndrome. Whereas in the Parkinson's context, you're getting that acute, severe, life-threatening dopamine deficiency state, but it's not because you're giving them an antipsychotic, hopefully, although you might be based on the dilemma we spoke about a few dilemmas ago, but it's more because of abruptly withdrawn or missed doses. So how do you identify Parkinson hyperpyrexia syndrome when you come across it? Just think about how neuroleptic malignant syndrome manifests and just think of that. And that's basically how Parkinson hyperpyrexia syndrome manifests. So mental status changes, protracted hyperthermia, so a high temperature. But there is a distinction between a fever and hyperthermia. So fever is when the hypothalamic thermoregulatory set point is raised, and then the body undertakes mechanisms in order to deliberately raise the core body temperature to meet the target that the hypothalamus has set. And maybe that's in the context of an infection, possibly to try and increase your metabolic rate to fight the infection, or it could be in the context of a non-infective cause of fever, like a malignancy or drug-induced fevers or an autoimmune disease. But then separate to that, you've got hyperthermia. So that's not because the hypothalamus's thermoregulatory target has increased, but it's because actually the target stayed where it always was, but for some other reason, the core body temperature has just risen anyway. And so in Parkinson hyperpyrexia syndrome, you get this stiffening and this rigidity and all this movement. It just causes an increase in your core body temperature, and it causes your temperature to rise even when it shouldn't. It's kind of like heat stroke, or if you've got a marathon runner who's just run a marathon in the middle of the day and they haven't been adequately hydrated and they're in a hot environment, hot ambient conditions, their body isn't trying to set their temperature high. It's not doing that. It's just they've been running out in the sun all day and they're doing lots of activity and they're not staying hydrated, and their body literally cannot thermoregulate, and so their body temperature raises to above what it should be. And you can get these really high, dangerous temperatures into the 40s or higher. Other signs and symptoms to look out for are autonomic dysfunction, so tachycardia, labile blood pressures, and really multi-organ dysfunction, just renal shutdown, hepatic shutdown, delirium, neurologic shutdown, everything just shuts down. And as I mentioned earlier, and as I hope that you're getting the flavor, this can be a fatal condition, so it's an emergency. So how do you treat it? Firstly, the patient should be really in a high intensity environment, so an HDU or an ICU environment for monitoring at a minimum, so cardiopulmonary monitoring. And then you need to institute temperature control, so active cooling, as you would treat anyone else with hyperthermia as opposed to fever, as I just spoke about at length. And then you need to, of course, treat the underlying problem by instituting sufficient dopaminergic therapies. And ideally, you would institute the therapies at the dose prior to whatever dose the patient was on when they didn't have the problem that they currently have. So if they were on regimen number 1 and then it was reduced to regimen number 2, and that second regimen is what's caused the current problem, just try and get them back onto the initial regimen that wasn't causing a problem. And that might include levodopa being administered through a nasogastric tube. It might include retigitine patches, or it might include subcutaneous apomorphine infusions. So you're doing whatever you need to do to reinstitute the dopaminergic therapy. In severe cases, other agents such as dantrolene, which are used in the treatment of neuroleptic malignant syndrome, can be used. So, that was everything that I had to present today. Thank you so much for tuning in. If you did enjoy the episode and if you learnt something, if you found it valuable, please do like, comment, and subscribe because it really helps the project grow. Visit our website at rneurologyeducation.org. That's R for the letter R, for all of our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms at R Neurology Education. Email us on contact@rneurologyeducation.org with any questions you may have or to subscribe for updates when new content is released. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.